Good morning, good afternoon, and good evening, wherever you are in the world. I am Livia Edegger, and I'm the Deputy Chief Executive of ISSUP, the International Society of Substance Use Professionals. I am with me here today is my colleague Goodman Zibeko, who is ISSUP Scientific Advisor. We would like to welcome you all to our final ISSUP Global Webinar of the year, in which we will explore prevention systems. This is also the first webinar of ISSUP Scientific Council. Goodman will tell you a little bit more about our Scientific Council after the introduction. The panel presentations today will provide an overview of global activities to strengthen prevention systems with specific examples from Europe and Oceania. And for those of you who are joining us for the first time, we are an international membership organization. At the moment, we have over 42,000 members around the world. Our members work in prevention, harm reduction, treatment, and recovery support. And we at ISSUP support our members with access to training and credentialing, with opportunities to build networks, share knowledge through our website, through our virtual and in-person events, and locally through our national chapters in 39 countries. If you're not yet an ISSUP member, we would like to invite you to join our network of drug demand reduction professionals. You can do so by visiting our website and applying for membership. Membership is for free. Before we get started, I'd like to run through a few logistical things. So at the end of today's presentations, we will have time for questions. So please send us your questions through the chat function of the GoToWebinar control panel, and we will try our best to answer and address as many questions as possible. And for those of you who want to rewatch the webinar or who want to share it with their colleagues, the recording will be available on our YouTube channel and also on our website. And just a quick reminder to everyone that the webinars hosted by ISSUP are provided for informational purposes only. They are educational in nature and do not constitute medical advice, diagnosis, or treatment. And Goodman will now introduce our first speaker. Over to you, Goodman.
Thank you very much, Livia. So colleagues, welcome. So while this is the final ISSUP Global Webinar for the year, this is the first webinar by our ISSUP's newly established Scientific Council, which we're really super excited about. The Scientific Council is composed of a group of scientists who provide scientific input to make sure that we're providing the ISSUP community with up-to-date research and information in response to the needs of the field in drug demand reduction on all issues relevant to ISSUP's mission to make the work of our members as impactful, accessible, and effective as possible. And as Livia has said, today's webinar is going to focus on prevention systems. So Kojo is going to share the link to the page for the ISSUP Scientific Council for you to learn more about and engage with our Scientific Council members. So prevention, as we all recognize, is an essential element of drug demand reduction. And while we need to ensure that we're ready to meet the needs of the population with substance use disorders or with problematic substance use, we're also aware we need to ensure we're providing individuals and communities the opportunity to access best practice interventions that facilitate a choice to prevent either any use or a progression to harmful use of substances. As a result of the complex nature of our environment and factors that impact on our exposures, our decisions, and our resulting relationships with substances, it follows that preventive interventions must be safe, effective, selected based on best evidence, and importantly, cannot stand alone, but must be located in the context and structure of a broader system. Today's webinar allows us to engage on the implications and needs for such a system to be established and effected. And hopefully you'll have a chance to engage with the pieces written by our speakers, which have been published in this week's ISSUP newsletter. The ISSUP staff is now going to provide the links in the chat for you to engage with those or to read later if you'd like to. So our speakers, as Livia said, are going to share reflections on prevention systems, and we encourage you please to engage with what's shared either via comments or questions for our Scientific Council panelists. Having said that, our first speaker today is Dr. Raquel Donini. a psychologist and psychotherapist who's based since 1995 at the public local agency, Department of Mental Health and Addiction. She's had many years of experience in the clinical and prevention field. And since 2007, she's been the head of the drug prevention unit. And her current work is about drug prevention planning and implementation, project management, and European project planning. In the last 15 years, she's been involved in several European projects aimed to improve and disseminate the science of prevention, such as the European Drug Prevention Quality Standards Project, the European Prevention Curriculum, and the Analysis of Systems and Professionals Training. And she is currently the local project manager for the Frontline Politeia project, which is funded by the European Union Commission. She's a member of the European Monitoring Center for Drugs and Drug Addiction, as well as on the advisory board for the implementation and dissemination of the EUPC. She is certified by EMCDDA as a European trainer for EUPC. Since 2019, Dr. Danini is in USPR's board of directors, and in 2020, she was awarded the USPR with Leading European Prevention Science Practitioner honor. So we're really honored to have her with us. And then since 2020, she's been a consultant EUDA and in the EUPC training and other prevention measures. And since 2021, she's been a consultant, thankfully, to the ISSUP Global in the development of INAP Plus course and in the training of its core facility. We're really excited to bring her on board now as an ISSUP Scientific Council member. And with that, Raquel, it's over to you. We're really excited to hear what you have to share with us today.
Thank you very much, Goodman. It's really an honor for me to be here as part of the Scientific Council, ISSUP Scientific Council, and it's also the first webinar from the Scientific Council, so I'm very honored to be here. And I would like to share my presentation about prevention systems. Hopefully it won't take that much, and hopefully it will help to follow a bit more this topic about prevention systems. So I will bring you a European perspective in the UNODC international standards, which of course Wadi will speak about more deeply than me. We have an overview of how a prevention system should be built to improve and to enhance the quality of prevention interventions. So we speak in the international standards about an integrated range of interventions in multiple settings, targeting relevant ages and different levels of risks. So we need supportive policies and legal frameworks that can really support the prevention interventions. So this is what the UNODC international standards tell us about prevention systems. What I would like to offer here is a European perspective that in some way brings together what also the international standards show to be effective for a prevention system to support prevention interventions. But it is also a little bit different. So I'm offering this European perspective because in 2019 and 2021, I was with my region, the Liguria region, the scientific coordinator of a European project called ISSUP, that stands for Analysis of Systems and Professional Training. So I would like to bring you this way of interpreting the prevention systems and the idea we had on how to use also the model that was offered by the European Drug Agency about prevention systems. So my talk is about what is a system, offering you this European perspective, and I will also offer you the experience of this European project and come to some conclusions. So a system is composed, sorry, something happened here again, yeah. A system is composed of a set of elements. So let's bear this in mind, a set of elements organized for a common purpose. This is very important, a set of elements for a common purpose that are connected. These elements are connected and interact the one with each other to form an integrated whole. So we can describe substance use prevention through the lens of a system. So let's remember, it's a set of elements for a common purpose that are connected and interact to form an integrated whole. So we have this model offered by the European Drug Agency about prevention systems. If you like, you can find this on the EUDA website, this technical report about exploring a system perspective. And what we did with the ISSUP training project was to use this model in some way to analyze, sorry, I'm trying to shift, to analyze the European systems. So I'm presenting very, very quickly what the UDA model looks like. So we have the elements, as we remember in the definition of a system. These elements are the organization of the system, the research and quality control, the interventions that are part of this drug prevention system, the workforce that delivers the interventions, and the target population that is addressed with these interventions. So these are the elements that are connected one to the other, and that do have also mediators that can help to improve these connections within the elements. And these connections, these mediators, can be the interaction with academia. We know that working with academia can enhance the quality of the organization, but especially the research and quality control. The intersectional cooperation between different bodies, institutional bodies, if it is in place, really enhances the quality of interventions. If I think at Italy, for example, the collaboration within the Ministry of Health with the Ministry of Education, for example, is really successful if we want to implement interventions in schools that can bring the health message to the students. So the mediators in some way can enhance the quality of our system. Yeah. There we go. Then we have the moderators. The moderators are a little bit more difficult to have an impact on, because those are the ones that cannot be easily modified, but nevertheless, we think that they have an influence on the overall delivery of prevention. And the moderators is, for example, the social capital or the policies in alcohol and tobacco. So what we did with the ISSUP training project was to use this model to analyze the prevention systems, and we linked the idea of the ISSUP training project was to link the prevention system analyzing, the prevention system analysis and profiling of systems, to the training of the workforce professionals, especially those that were in key positions to influence the allocation of resources and the decision-making about drug prevention. So what we did was to profile the European systems of 20 countries that did in some way wanted to be part of this project. And we also delivered a stakeholders map. So for each country, a stakeholder map was designed to identify those key stakeholders that in the prevention system held a position that could in some way have an impact on the prevention system. So the role was a role at a local, regional, or national level, depending on where we wanted to implement the interventions and the policies. So this is how we decided to gather all the information about the prevention systems in Europe. We built a questionnaire based on those five elements that I presented in the EUDA model. So we asked each country and each key stakeholder to describe the organization of their system, if research and quality control about drug prevention was in place, how did the drug prevention field have funding, was it a recurrent funding or was it just a project funding? So was it a systematic funding or not? And then to gather also information about what kind of interventions were implemented. Was the workforce a workforce dedicated to drug prevention or not? Did the workforce have training about implementing prevention interventions and the target group? So we gathered all these information through the questionnaire, and as I said, the questionnaire and the interview was submitted to those key stakeholders that were in the prevention system at a national, regional, or local level. And these are the general findings that come from 18 national prevention profiles. So what we discovered, thanks to the project, was that we could describe the systems in detail using the EUDA model. And we found that there is a really wide variety of drug prevention systems in Europe, and that have many different combinations based on those elements. We had manualized prevention programs in place, but also other programs that weren't evidence-based, but that were offered. And another common thing was that the decision makers needed to have some common competencies and skills for their role, and that important professional supporting systems and funding mechanisms were in place in different countries. And the people, the key stakeholders that were in that role in each country did perceive the drug prevention area as quite a prestigious place to be. And in almost all countries, there is a national drug strategy in place, not in all the countries, but in many. And in almost half of the countries, drug prevention is a separate domain. A national drug prevention action plan is adopted in less than half of the countries that we did describe. And this is an interesting finding. Large epidemiological research is in place to inform policy development. And there are in 15 countries out of 27 some kind of quality standards in place for drug prevention interventions. So this is the key stakeholders map. We had about 115 questionnaires submitted to the 20 member states, and here we asked to the key stakeholders if they wanted to engage with a training for DOPS, what we call DOPS, decision, opinion, and policy makers in Europe, if they wanted to go through a training that was the EUPC training, the European Prevention Curriculum training, to gather more information about decision-making in drug prevention and allocation of resources in drug prevention. So what we did during the project was to offer 2 sessions of training to these key stakeholders, and by the end of the project we had 56 master trainers that were able to gather information from the most updated and scientific knowledge on what works and what does not work in drug prevention. And so we say that from that moment on, from the ISSUP training on, the dissemination of the UPC really became a little bit more viral. It started really the dissemination in all the European countries. So the conclusions are that really prevention systems need to be kept into account. So the whole, not just the intervention, not just the workforce, we need to keep into account all the 5 elements that are part of our drug prevention system to enhance the quality of drug prevention. And this means also keeping together all the different elements and assuring interaction between all those elements. So what we can conclude is that a system is much more than the parts that form a system. It is much more. Here you see the parts of a bicycle, but of course, if we put all the elements together in interaction and connection, we have a bicycle that can move. Otherwise, they are just parts. So this is my presentation. Thank you very much.
Thank you very much, Raquel, for your presentation. And let's just see, I'm trying to. Yeah, thank you for providing us with this well, interesting overview and findings within the European context. And I mean, what we've seen that you mentioned a wide range of factors and elements need to be addressed, and then with that in mind, we can successfully implement substance use prevention programs and policies, and then build an effective prevention system. So I'm sure we will come back later to the involvement of the different elements and how they interact with each other that you mentioned, and also the involvement of the key stakeholders. Yes, so I'm sure we will discuss this later in our Q&A session at the end. So please, again, I would like to remind everyone to send us your questions in the chat. And thank you very much, Raquel, for the overview. Good. Moving on. Okay, perfect. It is now my pleasure to introduce our second speaker and esteemed Scientific Council member, Wadi Malouf from UNODC. Wadi is Program Manager in the Prevention, Treatment and Rehabilitation section of the United Nations Office on Drugs and Crime, UNODC. Wadi holds a PhD in Mental Health and Drug Education Epidemiology from Johns Hopkins School of Public Health. Wadi joined UNODC in 2005, first based in the Regional Office for Middle East and North Africa in Cairo, Egypt. In this capacity, he supported assessment of drug situations and development-related drug response strategies, while building technical assistance on availing evidence-based prevention of drug use and treatment of substance use disorders in the region. Since 2010, he started managing a global program on prevention of drug use, violence, and crime from UNODC headquarters in Vienna. This program promotes evidence-based prevention interventions and policies in line with the UNODC WHO international standards on drug use prevention. Further to the promotion of the standards, the program aims to develop pilot and assess the impact of family skills responses in preventing drug use, crime, and violence, including in humanitarian settings, as well as life skills education responses in schools and in sport settings. Thank you so much, Vadi, for joining us today. The floor is yours.
Thank you, Olivia, for the invite, for the nice introduction, and I thank also Raquel for also setting up the scene for the systems of prevention. I'm guessing, as this is the first webinar from the Scientific Council, also to mention that this sort of meeting is part of systems of prevention, really thinking in terms of the tools that exist, bridging with the academic experts, really to think through as part of a system of prevention. But I'm going to zoom in on the systems of prevention from an applicability perspective in terms of why it's essential now to focus on having such systems in place, building on what Raquel has mentioned. So yes, Raquel mentioned the fact that we have the international standards on drug use prevention that were done jointly between UNODC and WHO, noting that, you know, it was as a logo using the UNODC taking the lead, WHO standards being applied, but the evidence is an evidence of academic institutions and centers, including EUDA, EMCDDA previously, CCSA, many kind of think tanks, as well as researchers, such as those joining us online. I will not go through the content of the standards, but just to continue with the storyline leading to the discussion, the prevention standards, aside summarizing the evidence of what exists in preventing drug use, the main storyline of the standards is that prevention is person-centered. Not even we're talking about prevention of drug use. Drug is a component of the prevention response at a certain age, but it's the person that is the focal person of attention at different ages of development. The other element of the standard that's important is what I mentioned at the end of my sentence. It's developmental, meaning like every single age of development requires a certain attention to reach these milestones of development. The other part of the standards in terms of reflection is the fact that early prevention is key, meaning that, of course, there's an essential work to work at the age when problem behavior articulates itself as substance use, meaning adolescents in different spectrum of ages, but prevention can start as early as when the child is in the womb of the pregnant mother. That's how early it is, and the earlier we start, the better. And there are three essential reassuring factors that emanated from the standards as well. Aside reflecting on the evidence of the programs or policies that were documented by WHO standards that are effective for preventing drug use, we know other storylines as well. We know also that there is a combination effect, meaning that if you address a certain child through prevention intervention in more than one setting, like for example, through the school setting to build their own personal resilience, through life and social skills, and that same child happens to receive another evidence-based program, coincidentally, it's through a family skills program, building and nurturing a relationship between that child and his or her caregivers, that effect of the combined effect of these interventions in some instances is multiplicative and not additive, meaning that one intervention, when you're adding, as Raquel mentioned, you know, more and more elements, you're building something that can become a bike, if I'm using the analogy appropriately, but it's an amplified effect, you know, it's more than additive. There's another additional reassuring story that came from the evidence that's been reviewed. It's the fact that the earlier you start, because it's a person-centered approach, the outcome of your investment, that is an investment building the milestones of development at different ages, goes beyond a return of investment that is focused on preventing drug use, which is important from an investment perspective. The same vulnerability that you're addressing or protective factor that you're amplifying is getting you a reward in terms of preventing drug use, violence against children, mental health, school delinquency, and many other social negative health consequences that a person can reach at a certain age with the package that he's being receiving. Another reassuring factor as well is the fact, of course, as I mentioned in the beginning, there's a lot of evidence-based tools that are out there. You know, registries are becoming, there. Of course, translation of these registries and these evidence-based packages through policymakers is not at the level it should be, but to be positive, there's a lot of positive commitment in terms of listening in to the fact that, you know, prevention is a science. There is more and more sort of grounding with policymakers to appreciate the fact that not everything they call prevention is prevention. There is a science behind it. But also another reassuring thing beyond the listening ears of the policymakers and the presence of the registries of evidence-based practices, there are many other tools that are being developed in between service provision and policymakers, including, for instance, the presence of quality standards to improve the service provision of those that are providing prevention services. Also, there are also tools that are helping policymakers map out and understand their infrastructure of service provision of prevention. Raquel mentioned some of the tools in Europe. There is also a tool on the review of the prevention systems, meaning that tool that makes policymakers appreciate the infrastructure that it exists when it comes to prevention response, that goes beyond the narrow angle of thinking about what programs do I have talking about drugs, but more what programs do I have supporting child development in different ages, and accordingly orienting myself in terms of an investment beyond the narrow set of tools that I'm thinking of and capitalizing on the larger one and seeing how can I improve my investment to really move things forward. How can I really amplify the prevention services that I can build on? These tools that came into place lead us to an important sort of milestones in terms of reassuring the global community that there needs to be a better investment in prevention. It's not only the science that's there, it's the fact that, as Raquel mentioned, it's a combination of more than one element. The presence of evidence-based practices, the evidence-based tools and policies are key, but there is the system itself, the receptacle, the hardware that takes in all of this software and really kind of think through how it should offer these services to the population, the stakeholders that read, the beneficiaries. How much comprehensiveness we have in terms of the response, you know, that kind of overall framework, how much I'm covering in terms of different level of risks, different level of ages, how much I have supported policies and regulations, how much I'm undertaking evaluation in my research, both feeding in and monitoring and evaluation, how much my services are in place, how much coordination and coherence I have between the different stakeholders of the response. That work in silos as well, every sector operating by itself without really coordinating with the other is also waste of resources at best, right? But also it could be even worse in terms of effect, because there might be one providing a service and the other one a counterproductive service. So basically that coherence in the system, having a unified vision addressing all the different needs is key. How much there's competence in terms of the service delivery mechanism, the quality as implementation, sustainability of these things, all of these things are key over and beyond adding more and more evidence-based practices. That is what constitutes for us a system of prevention. And this is where, given that the presence of the tools are there, the political commitment is there, it's a period of time where investment of prevention should be showcased at scale, reflecting the fact that this scale-based prevention that is aligned by standards and guidelines and science within a system framework can really shift the developmental pathways of the beneficiaries, particularly if we're talking, which is the ideal situation, at early ages of development, in a very rewarding and cost-effective way, and with a big return on investment of development in different countries. So it's a period of importance of demonstrating such work at scale. And this is where, you know, the UNODC, for example, have launched initiatives like the CHAMPS initiative, to not only talk about putting such tools in place to set up systems, but document that such systems, when they're applied in this situation for children, meaning the less than 18, every single stakeholder that is related to development have something to put in as input for that system. And that same system has outputs that can benefit multiple sectors of the response, meaning that it is aligned by the prevention standards when it comes to drug use, but the educational sector, the social sector, the health sector, the community sector, the youth sector, whatever sector exists, the legal sector that is providing certain services that support a certain age of development aligned with the standards have something to contribute to, but also the output of that system is preventing, as I said, multiple outcomes that could be the primary outcome needed by every sector. And this is where it is that call of action for such systems that are in place that now is the appropriate time to put for it to invest in an appropriate way the limited resources that unfortunately exist in the field of prevention, and at the same time, by showcasing that these limited resources are doing the effect and giving you the return on effect that you need, we encourage further investment in prevention at a time where unfortunately also the need for such system, given the vulnerability and the crises that multiple countries are facing globally, need that investment now more than ever. So that's the general framework I would give in terms of the discussion that we will have. But as mentioned by Goodman, the links in terms of more details for what I've mentioned in terms of the thinking process is in the chat. And I move it back to you, Goodman or Lydia.
Wadi, thank you so much for that presentation and for stressing the fact that prevention is actually a science, and that not everything that we might do, even though we mean well, might be best practice. So it needs to be scientific and best practice based. You know, as you were speaking about the person-centricness of our DDR efforts, I found myself wondering, I don't have to answer this now, but when we have our conversation later, is how does one extend the person-centricness to communities, which may not entirely be all that homogeneous? We have quite a few questions which we'll hope to get to momentarily, but we will now move to our final speaker. So thank you, Wadi. So I'm going to introduce our next speaker, and I cannot believe, John, that you've made it. It's just, it's a crazy hour for you. Really appreciate you making it for today's session. Professor John Tumburu is the chair in health psychology within the School of Psychology at Deakin University. He's the co-leader of intervention science within the Seed Life Course Research Center, and is a prominent social advocate in areas related to child and adolescent mental health promotion and the prevention of alcohol and drug problems. He plays a leadership role in assisting the development of partnerships and research capacity within the school. He teaches at postgraduate level and also supervises higher degree students. Prof. Tumburu has been an influential leader internationally and nationally, and assisted in developing research and practice in the field of prevention science and health psychology. He's received international awards for his contributions in these areas and has been influential in reshaping Australia's health policy. We're really pleased and super proud to have you on our scientific council, John. And again, cannot believe you're up at this hour. So thank you for joining us. And so over to you for your remarks today.
Well, thank you very much for that introduction. And yes, I'm joining late because of technical problems at our end here. But it is also approaching 1 a.m. in the morning in Australia. So I am pleased that I was able to overcome those problems and join. And this is what an important topic. So it's really very important. We're all very keen to find answers to the issue of the devastation that we see with substance use problems across the world. The issue that I'm going to champion tonight is looking very much at the community level and taking evidence-based practices into communities. And I'm sure many of the listeners will be familiar that when we talk of communities, we're thinking of the places. It can be neighbourhoods, but it can also be communities of interest where we see that there's some groups with common ethnicity, or they may be from a specific socioeconomic background, and they form a target group that we're keen to be able to provide our prevention resources to. In the comments that I would make of this is, firstly, to say that I'm an enthusiast for this type of a model. I think that it's very important within all our other levels in terms of our state and national efforts and our attempts to set up a suitable policy environment, or to have work that we might do at different levels, that the community offers us generally a place where we can think about a whole range of the social ecological context. So within communities, we have educational systems, there are parents raising children, there are markets that are selling tobacco, alcohol, and increasingly cannabis. And it is in this environment that we seek to make a difference. The coalition model has been a particularly effective one that, in my experience, we've been able to find a way of getting through the complexity in order to work with the various stakeholders that will need to be marshalled if we're going to make a difference. It is a complex area. Generally, with community-based models, the evaluations tend to look for models that use more than one of the socio-ecological contexts. So community models will often be responding to markets as well as sending messages, behavioural messages to the broader community. So more than one evidence-based practice will be operating within a community model. There's lots of coalitions, but actually very few of them evaluate what they do. And so I'm a very keen researcher. And so from my practice, I particularly advocate models that have had evaluations. And I know there'll be many people practicing who don't have the luxury of having a relationship with institutions that can conduct research. But I do think it's very important for us to point out, from what we know of research, the models that have made a difference. So we know that we need a place to find these models, and I would very much recommend some of the work of the Evidence to Impact Collaborative, and this will be one when it is possible for you to obtain the paper that I'm sharing with you. You'll find that there's a link to this very important resource. So it's an example of evidence-based repositories that now are increasingly common in different countries. Of course, many of the models that we tend to look at have come from the United States because that's where there's been the greatest investment. In our own country here, in the experience in Australia, we're setting up repositories, and there are these repositories of evidence-based practice emerging in Europe as well. So whichever country you're in, it's good to advocate that this type of evidence-based practice information is made available. In the experience that I've had, the coalition training models that we see are very much dependent on the types of rigour and the ability to bring people together to follow evidence-based practice. And this is an important message that many coalitions seek to make change at a whole community level in reducing the problems of alcohol and tobacco and other drugs, but very few of them have been able to actually demonstrate that they can do this over time. And so it is good to take recourse to evidence-based models. The ones that I've particularly been interested in are those that have been able to marshal two or more evidence-based practices. So if we think of evidence-based practices, we can think of roadside breath testing to reduce the amount of, as a harm reduction strategy for alcohol. In my own country now, these roadside tests are also done for other drugs. And so the idea of that is to reduce the harm that occurs where people are using alcohol or other drugs as they drive. We can have brief interventions that run from health services, where we know these again have a good evidence base, that you might get a message from a doctor when you go to see a general practitioner, and that message is about asking you are you using tobacco, what's your level of alcohol use, and increasingly the question will be what products are you using that have cannabis in them. And then a brief message is given to try and alert you where you are using substances outside guidelines. So if a community is operating a campaign to try and reduce alcohol problems, and they're doing a number of different strategies, then we start to have an example of a community-based system operating. And so it is important to be aware that there are models that do work. So within all the evaluations, there are many models that haven't worked, but you will find that there's a number of them that are listed on the Evidence to Impact Collaborative, that actually you'll be able to find 141 programs that have been evidence from very rigorous trials. We've had very good experience with one of those programs here in Australia that's listed, which is the Community Care Coalition Training Model. And so that model offers a way of coming together to deliver evidence-based practices in the children and adolescent age group, with very good results in reducing problems in that age group within trials, both in our own country here in Australia and in the United States, but increasingly showing good feasibility in the European and the South American context. So perhaps I'll leave it there in order for there to be time for questions. And I hope that I've been able to share some information that you can follow up further to find out a bit more about community-based systems for prevention.
John, thank you very much. Personally, if it was 1 a.m., I would be snoring away. So again, thank you so much. But I'm sure you must be across time zone challenges. If I can ask the rest of our colleagues to please come back on camera so that we can start to engage. I think, John, what's really encouraging is that there's so much evidence for these community-based interventions, right? And it's great that you've contextualized the fact that there's ways to be opportunistic about how we engage in prevention activities, and really looking at that ISSUP model and being more intentional about how we incorporate it into policy. So really just thank you for that reflection. There's so many questions. So Olivia and I's job is made both easier and more difficult because we now have to choose, and we won't have enough time to get to all of them. So let's take a look and see where we start. So perhaps I can start with the first question while Olivia and I organize the rest of the questions by Oleksiy. I can't pronounce the surname, Konieko. Apologies if I spelled it wrong, if I pronounced it wrong. The question was asked during Raquel's presentation, but I think anybody can speak. The question is, do you see connections between the phenomena of European prevention for drug addictive youth behavior and health psychology basic knowledge? I don't know if you understand the question. Please go ahead, Raquel.
Thank you, Goodman. So if there are connections within the prevention system and the training of psychologists, is this the right formulation of the question?
Yes.
Yes. Thank you for this question. I'm a psychologist, so thank you very much for posing this question. I think there is remember the definition of our system as elements that are connected one to each other and have a common purpose. So as psychologists, of course, our main goal, our vision, is really to improve the skills of people, and especially now thinking about drug prevention interventions, to empower the skills of children and adolescents. So this is really one of the aims and goals and visions of the psychological work. So from this point of view, I would also ask and call for psychologists to widen their perspective, not only on the relationship with the patient, which for especially new entries, new psychologists, this is in some way the stereotype of the psychologist working as a psychotherapist in a relationship with the patient. But what I find is really important, I'm referring to the Italian background here, is really to widen the perspective to the health promotion field and to the idea that health is a public issue, so about public health. And from this perspective, I think that the prevention system approach for a psychologist is really, really interesting, and it's worth to take into consideration, because we really widen our field of interest not only to the target group, but also to the policies, also to the way we design interventions, also about the training of the key stakeholders, where psychologists can have an important role as trainers. So I really do see an interconnection about the work of a psychologist and the empowering of prevention systems, and in this case of drug prevention systems, but generally about health systems. Thank you.
Thank you, Raquel. We will continue with our next question, which is everybody can answer, but I'll maybe ask John to go first. So this one is from Aristea Ladas, and the question is, when can we consider that a combination of prevention strategies is too much? Might there be a point where if you combine too many different prevention strategies, that they might have then the opposite effect?
Yes, the answer is that it is very possible that you can try to do too much with prevention. So one of the issues there is just understanding that nothing really will work, no component of prevention strategies will work if it's not done well. So when I say well, it really does need to be done with the word fidelity comes in. So fidelity to the program logic, with enough reach so that you're capturing that effective intervention process and exposing a large enough group of people that it will make any difference to your national picture. And the models that we emphasize when we talk about evidence-based practice generally have a manual that can give you good guidance as to how it can be implemented. And so if things are, I mean, the reality of work in most of our efforts in health promotion is that we do tend to have to accept that things are messy. But if you allow yourself to work in too much of a free-form way without enough discipline around the fidelity, then you will not have any chance of effects. So it is really important to not take on more than you can manage, and it's better to just do one thing well. If you are able to do that, and then you're able to add a second thing or a third thing that you're doing well, then you're likely to have more impact because it'll reinforce the behaviour change. So the message is that multiple strategies can be a good thing because we know behavioural reinforcement from different socio-ecological levels can value add to the motivation for change. But if you're doing any of them badly, then they're going to be a waste of time. And this is the problem with multiple strategies.
Thank you, John.
Thank you so much, John. For time's sake, I mean, I have a reflection, but for time's sake, we'll we'll make sure that we cover the next question so that our audience has an opportunity. What if you don't mind tackling this next question? So I struggle with these names. I'm not even going to try. So the question is, do we have international organizations for prevention and a campaign against substance use disorders, just like we have for HIV/AIDS in Africa? And this individual is specifically curious about Nigeria, but I think particularly from the UNODC perspective, would you be aware of any of such packages for the continent or other areas of high need?
In terms of, I mean, the question is very vague in the sense of answering it, because there is, yes, there's a pool of academic institutions that can respond to it in different perspectives. If you're looking for Nigeria, looking for Africa, for example, there are diverse ISSUP chapters that exist. My understanding that there might be in the future SPR specific continental basis. All of these are part of the response. There are also on the political fora, there's several UN agencies that have a common position on drugs. UNODC being the central part, that's the secretariat of the commission in terms of addressing member state, in terms of assessing what kind of policies work and what does not work. That's another anchor to put in beyond academia from a policy perspective. And from an implementation perspective, there is many, depending on where they are. For example, EUDA, there is CCSA, there is NIDA, there is, you know, depending where you are, there are the African Union might have some opportunities as well in terms of implementation. When it comes in terms of a fund, much like the fund of HIV/AIDS, no, unfortunately, not as I'm aware of, but resources are more scattered and require more creativity in terms of like seeking them. But my impression is like, you know, I think these systematic approaches that we're thinking of are key in terms of rethinking pools of resources that can be put together in terms of, you know, really kind of capitalizing on sectors that exist, and as a person-centered approach and outputs that goes beyond just the small domain of drug use prevention, which is important, but the larger things in terms of development, like violence, violence against children. Each of these thematics have its own funding opportunities that can allow these systems to move forward. So for the sake of time, I will limit it to this. Hopefully it addresses it as much as possible. And thank you again, Livia and Goodman, for this opportunity.
Thank you very much, Adi, for that overview. Yes, as you said, unfortunately, we're at the end of the webinar. We did get really actually a large number of questions. So maybe we will come back to the three of you at some point, and maybe we could produce a written, something in writing maybe that we can share with our members. I think that would be great. There's a lot of interest in this topic. Maybe at some point we could have a second webinar on it. But again, now for the closing remarks, I will hand back over to Goodman.
So yes, thank you so much to John, Raquel, and Wadi for starting off our Scientific Council panel webinar series. We're super excited to have folks of your caliber as experts assisting ISSUP meet our scientific goals. So to everybody watching, I'm not being robbed. There's a contractor working in my house, so that's why you keep seeing someone walking behind me. So I'm not being robbed. So thank you so much for taking us through this very important element of DDR. Ladies and gentlemen, appreciate you very much, and this concludes this webinar. Thank you for attending. We hope you found this helpful, relevant, informative, stimulating today. So you're going to receive a follow-up email within 24 to 48 hours with a link to view the recording of today's webinar. We always appreciate your feedback and suggestions, so please use the link in the follow-up email to fill out the feedback survey and be honest and tell us what you really think. On behalf of ISSUP, thank you so much for joining us today. Have a great rest of your day, morning, and please go back to bed, John. Thank you, everyone, and see you on our next webinar. Bye.
Bye.